Welcome to Citizens Reunited to Overcome Cancer, a show to make your survivorship an easier journey by providing information and advocating for you. A show to help practitioners up their game and their level of performance. This is the Croc Podcast. Here is your host, Dr. E, and alongside him to share some hope and inspiration from the Have Faith, Let It Begin podcast, co-host Angel Santana.
Hi, everybody. This is Dr. Eanelli, the founder and director of Citizens Reunited to Overcome Cancer. Tonight, I am humbled and grateful that you decided to join this week's podcast. I truly believe that today's program will resonate with all of us, as it's about a phenomenon we all have either witnessed or perpetuated. Today's podcast is entitled Physicians Criticizing Other Physicians to Patients. I know it should never happen, but sadly it happens too often, and it diminishes all of us. It diminishes the physician by exposing our insecurities and our own personal anxieties, which diminishes our patients by making them feel confused and distressed. Join me, as always, my co-host, Angel Santana. Angel, welcome.
Hello, everyone, and welcome back to the Citizens Reunited to Overcome Cancer. I'm excited because this is something that I think anyone can relate to. So I'm looking forward to today's episode, and I hope everybody had a blessed and an amazing Thanksgiving week.
Yeah, thank you, Angel. And I know you worked hard and you worked all through Thanksgiving, and we appreciate you. But as you said, let's dive right in. Although we will discuss 4 scenarios that I personally experienced in the clinic, I want to first start by doing a shout out to our paper's authors. I owe a great deal of assistance to Dr. Susan McDaniel and Dr. Diane Morse from the University of Rochester, whose scholarly article by the same title was instrumental to my understanding of this atrocity. Let's start with the AMA's description of what constitutes a disruptive physician. So a disruptive physician is one who uses language that is belittling, berating, disrespectful, and inappropriate. It accumulates in the destruction of the most important aspect to patient care, the aspect of teamwork. Angel, as the director of the switchboard, you know how important it is to bring people together. All departments, all situations and circumstances, you need that teamwork. And in medicine, on the clinical side, teamwork is the first step in a survivor's cure, as no one physician can manage all aspects of patient care. So good teamwork involves the exchange of information, the coordination of referrals, the evolution of a multidisciplinary evidence-based treatment plan consensus, and continuity of care, starting with diagnosis, proceeding through planning and execution of the treatment, and follows the survivor indefinitely through their survivorship. But what happens when teamwork is tainted by the stain of interprofessional, I call it trash talking? So you get now poor coordination, you have destruction of trust, you get conflicting information, which causes confusion and distress, that these patients, our survivors, they realize that their serious life-threatening illness is being managed like a bad reality TV show. The patients feel they are being squeezed, like in a rugby scrum of immaturity, of their physician's immaturity. So all of these factors lead to a very concerning outcome. It causes ineffective treatment due to delays and noncompliance. If I was a patient, I wouldn't listen to doctors who were confusing me. It may cause patients increasing pain. So not just physical pain, although physical pain is something that they studied in this paper, but also psychological pain. It increases the medical legal ramifications, so there's higher amounts of lawsuits. It reduces patient satisfaction. It reduces quality of health care, and it reduces staff well-being. But the most important thing it does is it increases patient mortality. So actually outcomes are worse when physicians are talking bad amongst themselves. So exactly how ubiquitous is the situation? So according to the paper, which involved the taping and recording of conversations between physicians and their patients. According to McDaniel's paper, only 29% of the interactions were rated as supportive. 67%, greater than two-thirds, were reviewed and rated as critical, and 4% were rated as neutral. So, Angel, there's 4 categories of the physician criticism, and as well as I'm going to add to my personal vignette, so my own personal experiences in the clinic. So, first question that I would ask, and which I'm going to ask everyone, is why do it? Why do our doctors talk trash amongst themselves? So, physicians are educated, extremely educated, extremely well trained, who take an actual oath to put the needs of their patients above their own needs. So why would they ever resort to just, such immature and infantile behavior? And the fancy psychobabble name to this phenomenon is called triangulation. So what this means in simple terms is physician anxiety is caused by stress. It's caused by responsibility, it's caused by time restraints, and it's caused by our own human frailties. And believe it or not, when you talk trash about another physician, you're actually relieving some of this. You're kind of blowing off some steam. You're relieving this by allocating blame to others, right? Unfortunately, the anxiety that's being lost by the physicians is being passed on to the anxiety of the survivors. So we'll get to the anecdote, which is called detriangulation shortly. But let's start with understandable situations which can cause this cascade. So why doctors might be, motivated to start trash talking. So number one, say a patient comes to you without a clue. So as a tertiary care referral, as a referring physician who gets, who wants their patients to see me, it's their responsibility to let them know why, what they have, what their stage is, what their prognosis is, and why they're coming to see a radiation oncologist. But more often than not, Angel, patients come to us without a clue, at times not even knowing they have cancer. So when a patient steps in the room and we go in to talk to them about what we're going to do for them, they're asking, why am I here? So that's certainly a great opportunity for me to start bashing their referring physician. A patient can come to you being told by a non-specialist of the care that they should receive by the specialist. So I can't even count how many times a doctor will say, oh, you just go see Eanelli, he's going to give you 5 days of radiation. And of course, that's never the case, right? And of course, the patient's very upset because they have expectations which are not aligning with the reality. A patient can come to us with unrealistic expectations about cure or about, as I mentioned before, about their treatments that we can't achieve. And that would certainly frustrate you. And a patient can come to us with what I call a half-ass workup. That means the patient comes to us and they haven't done the physician referring the patient hasn't done their job. So then we have to kind of pick up the slack and do our job plus their job, and which causes frustration and, of course, starts the wheels turning as to, oh my God, wait till I get my hands on this guy. And sometimes that bleeds over to the conversation with the patients. So, Angel, I'm going to give you 4 vignettes, and I want you to tell me, because this is very visceral, how you would feel if you were the patient, right? So the first category is criticism of another specialty. So I'll call the first patient Elizabeth, who is a lovely 87-year-old breast cancer survivor with widespread metastatic disease. Oh, did I mention she's 87 years old? She also has a ton of other medical problems, so she's very sick. And she's got this ulcerating, painful, draining, malodorous, smelly breast mass. So radiation therapy was recommended by the oncologist. The patient saw me. I recommended the radiation as well. And the surgical oncologist said, why would you get radiation? I'll just chop your breast off. Angel, how would that make you feel?
Wow. Well, I've got a couple comments, but I guess I'll just go with from this first. I think that I think that there's a fine line between how it's not what you say, it's how you say it. And it all stems back to the beginning. And forgive me if I'm kind of backtracking just a little bit, because that intro that you gave about teamwork really resonated with me. And I think it holds true to what you just gave me that you want an opinion on. And that is a good teamwork, means communication. And the communication between the staff, the doctor, and the doctor staff and the patient really fits like a glove, right? So to be very clear and honest with you, respectful communication, it means being willing to listen even when you disagree. So in this situation, when a patient is already older, maybe already filled with anxiety of her own, Elizabeth, and with all this stuff that's coming in, for the doctor to just come out and say, well, we're going to do this, and use words like chopped, it's just not something that would resonate with me as a family member or the patient, as a patient.
Right. I mean, so all the other stuff, all I want is your visceral response. So this, your
I would just be like,
oncologist
what?
tells you exactly. Well, that's what I'm trying to get at, is that your doctor tells you that, you need to have radiation because your quality of life is terrible. And, you get 16 days of radiation and it'll help you. And then your surgeon, says, well, why are you going to this guy for radiation? That's the dumbest thing you could ever do. Just come to me. I'll put you to sleep and I'll just chop your breast off. I'm asking you how you feel in your, like, just that, specifically how you would feel.
I would be nauseous and really angry.
Yeah, right. So that's what I thought. The next subcategory is criticism of a prior treatment. So Susan is a lovely 67-year-old breast cancer survivor with all favorable prognosticators, which is just a fancy word for all of her features were perfectly, low risk. So small tumor, low grade, good margins, favorable receptors, no nodes, low OncoDX, which means that no chemotherapy was being recommended by the medical oncologist. And the family practitioner saw the patient. Oh, Susan, I understand that you had surgery for your breast cancer and now you're getting radiation. To be honest with you, I don't know why your medical oncologist didn't give you chemo. I would have given you chemo. Angel, how would you feel?
I would be confused and say, what do you mean? What? I'm stunned by that. I don't even know why it was. I'd probably be speechless, but I would respond in anger and say, what? Why am I here then?
Exactly. I mean, the point is that these are real. This happens. I've seen, this is what I've seen in the clinic. And that's the motivation for the podcast. So third category is criticism of physicians in general. So Marie is a lovely 74-year-old newly diagnosed lung cancer patient who unfortunately presented with metastatic disease right from the beginning. So it wasn't like a stage 1 or 2. It was a stage 4. And she had metastasis to the liver and to the bone. And after 4 months of chemotherapy, they did some films to see how she was doing with the chemotherapy. Now, the radiologist said that the tumor had gotten worse, but they were comparing the films from October to November instead of looking at the original films from July, where there was a huge response from July to November. The medical oncologist said to Marie, your cancer is progressing, and this is a really bad thing, and we need to change your chemotherapy immediately. And then the cover oncologist, who just happened to be on call, who actually took the time to look at the films and review all the films, said, Marie, you're actually doing very well. You're responding very briskly to your therapy. Your other doctors were just too lazy or too busy to take the time to review all of your films. Angel, how would you feel about that?
Wow, I think, oh man, I'm telling you, I think the first thing I would be concerned about is, why is this person bad-mouthing another doctor? And then I would say, wait a minute, I don't know what to do. Who do I trust? If one can talk about the other, who's trustworthy here?
Well, not only that, but think about this. I mean, talk about confusion. One doctor is telling you pretty much to go buy your cemetery plot. And the other doctor is saying, well, things are not as bleak as you think. I mean, these are things that are huge. I mean, now what we're going to get to when we talk about the antidote is how the physicians could have handled these 4 scenarios a little better. Getting back to your original point, about communication, and it's how you say things. And we'll go back and we'll look at those things as well. As a matter of fact, I think that's a great idea. The fourth category is what's called ad hominem. And I've never heard of this, actually never heard of this before, but if you watch TV and you watch the news or you watch anything political, we're seeing this now on a daily basis. So let's in the American political arena. So let's break down what ad hominem means. So it means that a person is being attacked or a person is attacking an opponent's character or characteristics rather than addressing the issue or the statement. So there's a statement, there's an issue, there's a point, to be debated, but instead of debating the point, everyone's attacking each other. So they're attacking each other's quality and their candidacy and just whatever, their intelligence. They're attacking the person. They're not getting to the meat of the subject. So this actually personally involved me. So Matt's a 33-year-old fine young man, or he was a 33-year-old fine young man who had lung cancer diagnosed very early. He successfully received preoperative chemotherapy and radiation, perfectly delivered to the latest standards of care with an excellent and brisk response. Patient had the surgery, but he died of a surgical complication. The surgeon called me to berate my care and blame me for the young man's death, so he wouldn't be blamed. And he documented in his chart that it was the radiation therapy's fault that the patient died, not because of the surgery. And I did everything possible to protest this. I actually sent him articles and NCCN guidelines, which are basically the standard of care guidelines. And luckily, I had a really great relationship with the family. Otherwise, I would have definitely been sued for sure. But this is called ad hominem. Angel, your thoughts about that?
My first question to you is, what was your first reaction? I know you want mine, but what was yours? If I have to ask you first.
Yeah, I was angry, but I don't care about how I felt. I want to know how you would feel as the patient or the patient's family.
Obliterated. I just completely sidesstruck. I can't even get the words out of all these stories, and this one is the icing on the cake for me. I would just be like, what, pardon my French, what the hell is going on here?
Well, I would be, to the point. I mean, if you lost your 33-year-old son and you were told by one of your doctors that you trusted enough to crack your son's chest open, and you're told that he's only dead because of his radiation, I would be kind of like, I would say,
but you're in the situation. Sorry,
pissed, but I would not be happy. That's for sure.
And I think, I don't mean to cut you off, but I guess I don't know. Just don't know. It's hard because I'm trying to think as a dad right now, even though I have a youngster. I just wouldn't know where my anger would be first.
Yeah, no, you would agree that all of this is unacceptable. Yes,
absolutely.
Okay. So let's talk about solutions. So for the survivors, it's crucial that the survivors know that they do not deserve to be put in that position. They need to be empowered, and hopefully by listening to this podcast every week or every 2 weeks, they get this information so they feel empowered to stand up and advocate for themselves. So I'll give you a little sort of role playing. So, excuse me, doctor, but your statements about my other doctors are making me feel very uncomfortable, and I feel you're being inappropriate and unhelpful. Would you please consider restating your analysis? And if you feel there is a problem, please contact your colleague directly without involving me. So I think for the survivor, if they know this and they know this is not a thing that they should accept, they need to stand up for themselves. And I would hope that the doctors who do this, and I think we all do it at some point, we do it, forget about doctors and patients, but just in life, I think we're always kind of trying to, slather the blame elsewhere. I think it's part of our nature. I just think that survivors have to know that that's not something they need to accept. So that's for the survivors. For the physicians, it's much more complicated. So as a physician, we need to remember our oath and responsibility is always first about our patients and not about ourselves. And we need to elevate our behavior above our own demons and insecurities and frustrations. And we never need to have a situation where we need to badmouth or trash talk a colleague. We need to really seep ourselves like tea bags into the warm water of compassion, empathy, and non-reactivity. And we need to suppress our own personality dysfunctions and our habitual holier than thou attitudes, and take the extra time when we do disagree with a colleague. And we have to actually pick up a phone, imagine this, Angel, and actually call the doctor and find out what they're thinking and actually solve the rift without involving the patient, right? So you would be shocked, because I'm actually shocked how many times I go into a discussion convinced that I'm right and I'm not. So you might even learn something by doing this. And you need to learn diplomacy rather than to be incendiary and be that incendiary device that starts this cascade of bull dookie, right? Is that a fair? This is a family
We
show,
make
so we'll
words
say
up here. We make
right.
words up.
Now we're going to go backwards. We're going to go back to those four scenarios, and you and I are going to try to see how we can solve this, how it could have been done better, to your point, Angel. So Elizabeth, 87-year-old breast cancer survivor, who was going to have radiation, but the surgeon said, "Why would you ever have radiation? I'm going to chop your breast off." So if the surgeon didn't agree with the radiation for whatever reason, they certainly could have called me and said, "Hey, listen, I know you saw Elizabeth and I know you want to give her radiation. Not that there's anything wrong with that," because if they thought there was something wrong with it, then we're dealing with someone who's not logical, and it's just going to be a circular conversation. But if it's someone who's reasonable, you can say, "Well, surgery doesn't seem reasonable to the medical oncologist nor to me to try to have an 87-year-old terminally ill woman who's got 6 months to live, put them through anesthesia, surgery, and all this kind of stuff with the wound care and trying to recover, when I could give them 16 days of non-invasive therapy, try to convince me otherwise." And perhaps, again, if the person was a logical colleague, we could, have a very profitable discussion about it and not have to involve the patient. So, and if you do give your opinion to the patient, use words other than "chop your breast off." Say, "Radiation may be is appropriate, but I want to give you another option. I could do what's called a toilet mastectomy. You can be out of the hospital in 3 days, and that would be another option." So I wouldn't have a problem with them stating their opinion, as long as it wasn't done in the way that they did it, where they criticized another specialty's, effectiveness. Susan, criticism of prior treatment. She is our 67-year-old breast cancer survivor who was not offered chemotherapy, appropriately so, whose primary care physician thought she should have gotten chemo. So my advice for the family practitioner is stop pretending you're a medical oncologist. If you are confused as to why your patient didn't get chemotherapy and you just feel like she should have gotten chemotherapy just because, quote unquote, just because, not for any scientific reason, call the medical oncologist. Ask why they didn't give your patient chemotherapy, if that's something that really is concerning you. So that's the way that scenario, I think, should have gone. Criticism of physicians in general, that whole radiology mess. So everything was perfect. Well, first of all, the oncologist and the radiologist did a shit job. They really did a terrible job. They didn't look at all the x-rays. So that's unforgivable. But the covering oncologist could have been the hero here instead of being the GOAT, right? They should have been the hero. They should have stepped up and said, "Hey, listen, I have some really good news for you. I want to double check this, but from my review of your x-rays, which go back to July, not back to October, there's actually some good news that your tumor is responding to the treatment. You may have to change treatments because maybe it's not starting to be effective now, but you're way better off now than you were several months ago. And let me talk to the radiologist so they can serve an addendum to their report, and then talk to the oncologist to review all the x-rays as well, and then talk to you about showing you the films and going on with your new treatment perspective or your new treatment regimen." So I think that would be a good way of approaching that without bashing the other doctors. And the ad hominem with my friend, the thoracic surgeon, I'm not sure if there's an explanation on that, because it just appears that this was a very mean-spirited and terrible individual who just basically cared more about their own reputation and about their outcomes and about them potentially getting sued, and just tried to basically, they were the ugliest woman in the lifeboat on the Titanic. They took a mop, they took the top of the mop off, put it on top of their head, and pretended to be a woman in distress so they can get on the life raft. So I don't know if I have an answer to that, but I do have a conclusion to this podcast. So there is a caveat emptor, which means let the buyer beware. There are situations when we encounter deficient decisions by our colleagues, or even clearly inappropriate care, meaning care that does not meet the evidence-based criteria. And a change in providers is going to be necessary to protect and serve our patients. But we can perform this task with dignity and elegance and professionalism without bashing or criticizing. So Memorial Sloan Kettering is a great example of diplomacy. Most of the time, there are some turkeys amongst these practitioners. I said that metaphorically for Thanksgiving, but it is a world-class cancer center. And on the whole, their doctors, I have found them to be simultaneously outstanding practitioners and outstanding ambassadors for quality of care. They love to work with, and I use the term manage up the referring community physicians, because we don't have all their, access to the things that they have. Rather than bashing us, they actually manage us up and they teach us. And they are supportive and appreciative of us because we refer them to patients. And as a result, it's no surprise to me that the outcomes at Memorial are excellent. They provide higher quality of care. They reduce pain and length of stay. They increase patient functionality, and they have a very, very good safety profile. So my hat tips off to Memorial for doing it the right way. And then finally, in closing, as we as hospitals and as practitioners and physicians, as we become more focused on the patient, so we call that patient-centric care, the training of our student doctors and house staff, so the residents, we have to make sure that they are self-aware and monitor their own expressions of frustration, and we have to monitor our own. Expressing one's own opinions about diagnoses and treatments with acknowledging disagreement with other doctors, if necessary, for evidence-based patient care can be accomplished, as I said, without constigating or insulting words. But I know it's not going to be easy. We are human. We are frail. No matter how extensive our education and our training, we need to be forever vigilant to provoke and prevent any endeavor that may cause our survivors any pain or suffering, or especially confusion. As Shakespeare once said, the fault lies not in our stars, but in ourselves. Angel, your thoughts about the podcast?
Okay, so I've had a few seconds to take a breather.
Yes.
You hit me with this crazy thing. Let me just start off by saying this.
Yeah.
Not every doctor behaves this way, right? We can agree to that. But in the stories we heard, some used words that frightened patients or created confusion. Doctors must choose their language carefully and avoid criticizing or blaming colleagues. Instead, they should communicate directly, to work together, to find clearer, safer, and less invasive options before considering surgeries. When two professionals collaborate, patients receive better understanding and better care. Unity, not ego, produces the best outcomes. In the end, doctors must remember their purpose: to guide, to comfort, to provide the highest level of treatment through compassion, respect, and teamwork. You could tell I'm already going. I feel like this is a sermon.
You're doing great, baby. Keep it up. I understand in your way.
Let me close off on my spiritual aspect that I bring to the show. To every doctor, remember that your words carry weight, your tone carries power, your compassion carries healing. And before you speak, pause. Let wisdom guide your tongue and humility guide your actions. Work together, not apart. For one who heals alone, when you join your gifts, your knowledge, your hearts. You become instruments of grace for every patient you serve. So think before you speak, unite before you judge, and let your care reflect the light that you are called to share.
Angel, I cannot add anything to that beautiful conclusion. However, I will add our Croc blessing on behalf of you, myself, and the board of directors at Citizens Reunited to Overcome Cancer. We wish all of our survivors a long, healthy, happy, and cancer-free life. God bless you. God be with you. Peace.
We thank you for listening to today's episode of the Croc Podcast. We want to let you know that because of this episode, you'll have a special opportunity tomorrow on Have Faith Let It Begin podcast, where Dr. Eanelli will be joining myself and to share his thoughts and personal views on everything we just discussed today. We're collaborating. And here's something exciting. If you head over to tomorrow's Have Faith Let It Begin episode and listen for the special giveaway detail, the first 5 people who interact with us on social media and sharing what they've learned, how this episode spoke to them, and how their own stories relate, we will receive an autographed prize. We hope you enjoyed today's conversation. We truly hope you'll join us again tomorrow. Thank you. Have a blessed day, and we'll see you next 2 weeks for another episode of the Croc Podcast.
Hey, Croc Nation, if today's message inspired you, please subscribe, download, and share this episode with your friends or someone who you believe needs it. Visit us at crocvip.com to connect, learn, and join the fight. Let's spread hope, one story at a time. Until next time, remember, we are not just a podcast, we are a movement.